Hi, my name's Sue Mallet. Welcome to this short course on designing diagnostic test accuracy studies. The absolute essentials you need to know. I work at the Centre for Medical Imaging at UCL in London in the UK, and I'm going to share with you important tips I've learned in designing these studies across the last 20 years. The introduction to diagnostic accuracy studies is a series of short videos, each highlighting a key learning point. In each video, there are short activities where I encourage you to pause the video and think. If you're watching with colleagues, this is a great opportunity to discuss together. After each activity slide, I'll share with you my thoughts and insights. This is part 5, early phase or clinical phase studies. Diagnostic accuracy studies can be thought of in different phases, much as intervention studies, and these have different aims. For example, you can start off with early phase studies, and these are very explanatory and experimental studies. They might be working out whether a biomarker has a higher level in people with disease versus people without disease. There are also a second set of early phase studies where you're actually, again, you're still explaining things in your explanatory phase, but you're doing analytical studies. So you might be looking at how repeatable the measurement is and what its measurement error is. And these studies are all about understanding the test. But then there's another phase, which are clinical phase studies, which are very pragmatic studies. And this is about understanding how you would make clinical decisions with these tests. So it's actually often thinking about how the accuracy would be in a clinical population. So when we're thinking about these three phases, in that explanatory early phase where we're very experimental and we're really just looking for associations, we might be getting samples out the freezer. When we're in that early explanatory phase, we might be looking at healthy controls. Here I've got a picture of medical students, and then comparing those with people with disease. And in the clinical phase study, we're trying to recruit a clinical set of patients to the study. And in the clinical phase, we're trying to recruit a clinical set of patients representative of those who would have the test in normal clinical practice. Those are the people we want in our study. So let's have a little pause and think exercise. So if we've got an objective of a diagnostic accuracy of a sputum test for diagnosis of lung cancer in patients presenting to their primary care doctor, I'd like you to think about studies using different samples. And if we had studies that we found in the literature, which ones should we include in our systematic review of accuracy, of test accuracy for patients in primary care, and why should we include studies with these particular characteristics? Okay, so should we include studies that were done on rats? Should we include studies on patients having surgery for lung cancer? Should we include studies from the literature that are on patients with clinical suspicion attending primary care? Or should we include studies that were on freezer samples of at least 5 years of various lung cancer and comparing those to healthy medical students? Okay, so you're writing the systematic review. Which of these studies would you like to have when your study objective is looking at diagnostic accuracy for lung cancer of patients presenting to their primary care doctor? Okay, welcome back to the pause and think exercise. So did you want to include the studies of rats in your systematic review of test accuracy for patients in primary care? No. The reason is, while a study in rats is a fine study as you're in the early stages of developing a test, it's not going to tell you anything about how the test will perform in humans. We want to use the test in humans. We need data from humans. Okay, what about a study that used freezer samples from the last 5 years with various lung cancers and then compared the result from those to results in healthy medical students? No, we don't want those either. We're not really studying the diagnostic accuracy of a freezer. We want to actually study the diagnostic accuracy on a set of patients who might be clinically representative. Okay, should we use patients having surgery for lung cancer? How about that? Okay, now let's see what type of patients did we have in our objective. We had patients presenting to their primary care doctor. Okay, no, these patients already are known to have lung cancer. They're having surgery for lung cancer. So they're not, we can't test the diagnostic accuracy of a test in these patients. What about patients with clinical suspicion of lung cancer attending primary care? Yeah, this is the set of people we want to use the test for, and these are the set of people we want in a study that's going to be where we're going to look at the accuracy for use in primary care. And that's our systematic review. And our systematic review is to look at the evidence for accuracy for patients in primary care. Okay, so who are the patients? It's completely appropriate for an early developmental study that's not yet ready to be included in where we're just starting to develop a test. That's completely appropriate to use sort of freezer leftovers from other studies, or patients where the disease status is already known, or the extremely healthy and severely ill. That's completely fine, and that's a really important step in developing a new test. We're studying a freezer. But when we get through to a clinical phase study, we want to know whether the study has applicability in a clinical population. So we want participants who are typical of those who would have the test in clinical practice. And so we want defined eligibility criteria for the patients. We want to be looking to use the test and understand how it performs in patients who are typical of those who would have the test in clinical practice. So let's look at what the study design includes. So if we have an early phase study, it's likely we've got a whole set of samples that are somewhere in the freezer, and we're going to do sort of some pipetting in the lab, and we're going to have some sort of assay, and then we're going to be looking at the results. Okay, but if we're doing a clinical study, we're going to be recruiting clinical patients. We're going to be recording results on clinical report forms. We've got a protocol, we've got a statistical analysis plan, we've got people who are meeting the patients, and we're going to produce something that could go into guidelines. Okay, so again, what are the things we're actually analysing in these early phase studies? Well, we're starting off with the first proof of concept. We're looking at the association of our test result with disease. And as I say, it's completely fine to have severe disease and healthy patients. That's completely appropriate. We're developing a test. We're doing the development work. And when we've actually found there is an association with disease, then we want to know, can we identify disease? So can we separate the disease and the healthy patients? And so again, it's completely appropriate to have a set of patients with severe disease and completely healthy patients. That's fine. We just want proof that we can identify disease. But when we get onto that clinical phase, the question we're asking is we want proof that it's clinically useful, and then we want to get diagnostic accuracy, and then we want to have patients who would usually attend the clinic. Okay, so what we're seeing here is that different phases of studies have different types of patients included. So that one's a freezer samples, freezer and healthy controls, and here's our real-life patients. Okay, and when we're actually writing, if it's us who's writing up the study, we might want to avoid using sensitivity and specificity in the experimental and analytical studies, because the problem is someone might think that those results, sensitivity and specificity, belong to patients in clinical practice. And to be frank, when we're developing a test, we're not trying to do that. We're not at that stage, so we don't want anyone to misinterpret our results. So one way we can do that is actually avoid using the words that are used in clinical phase studies. And when you're getting to this these studies where you're doing the proof of concept of separating diseased and healthy, if you're looking at published results, really check very carefully, because these studies are quite likely to use sensitivity and specificity, and make sure that they're actually talking about a clinical population and it's the same clinical population you're interested in. That's great. We can use sensitivity and specificity in that final clinical phase, and these are the studies where, for our systematic review, we want to extract those results. We don't want the results from these two types of studies. They're not going to be helpful to understanding how a test will perform in clinical practice. Okay, so what we've learnt is that we need studies to be conducted in normal clinical practice on patients who would usually get the test and unselected patients. And we want to watch out for a few words in the study design that might indicate that a study might not be suitable in our systematic review. It might be the words case control, it might be the words healthy controls, but it might be a whole bunch of other things. And so here's an interesting article helping you think about the different labels and how we talk about these tests. And when we've got this test accuracy study from the perfect set of patients and everything, is that sufficient for us to know that the test would be useful in clinical practice? And the answer is no. Test accuracy is not the complete picture. It's part of the journey, but it may not be totally sufficient, because there are other many important features of a test too. We need to think about patient outcomes, and we need to think about economic and society outcomes. So here's the pathway we quite often find. The patients come along, they have the test, and that test is then used to decide on a treatment for them. If there is no treatment, that test might be about knowledge, which may be very valuable, but we don't really want tests for things where there's no treatment and people don't want the knowledge. Okay? And when after the treatment comes the patient outcomes, and again, not all of the treatments will change the outcomes. If the treatment doesn't change the outcomes, maybe people don't want to have the side effects, which there invariably are from any treatment, if their outcome is not going to improve. So okay, here's a little pause and think exercise for you. Here's a number of properties that are coming from a test. We're thinking about a diagnostic test for TB, tuberculosis, to be used in sub-Saharan Africa. So we're going to have a number of test properties, and I want you to think about why these might be important. And I also want you to think of other properties of the test that might also be really important. So this test takes 3 days to complete. The sample needs to be stored and transported at low temperature. The test needs expensive laboratory equipment and trained staff to compete, and the test can be done as a point of care by local healthcare staff. Okay, pause the video and think about why these properties might influence whether a test was actually useful in sub-Saharan Africa, where there may not be access to laboratory facilities, and think of other important properties you would like to know about a test for TB. Hi, welcome back. I hope you enjoyed thinking about those different properties of the test. Well, test takes 3 days to complete. That can be really problematic for TB, because often people in more rural areas can't afford to come and get the bus and the transport to where they would get the test, and they maybe can't afford to take 2 days off work, so they don't want to have the test one day and then have to come back again another day to get the result. So tests that can be done as point of care by local healthcare staff are always going to be better than something that takes days to complete. Now, in some rural areas in sub-Saharan Africa, it is really tricky to have a cold chain for storing and transporting samples. So if your test sample needs to be stored at low temperature, that may not be a suitable test in all locations. Again, expensive laboratory test equipment and trained staff is not always going to be available in all different countries and parts of the world. The most useful type of test is going to be this one, where we can actually see that the test can be done by local healthcare staff as point of care. So other important properties of a test you might want to know about include things like whether the test for TB also provides information on drug resistance, which would help you decide on the best treatment. Is a test affordable? Is it acceptable? Taking the sample, is that acceptable to the people who would take the test, or is it too embarrassing or invasive? Are the test results easy to interpret? It's all very well local point of care staff doing the test, but are the results easy to interpret? And is the test reproducible? Does it have a low failure rate? Can it be run easily as a large batch and also as a single sample? Again, these are important test properties when you're actually practically wanting to use a test in different areas. So where does diagnostic accuracy fit into how useful a test is, or test efficacy? So here we are, accuracy is this bit here. So this is about the clinical performance of a test. Does the test correctly predict the outcomes? But we might also be interested in knowing whether the results are repeatable, what happens beyond clinical accuracy, is it cost effective, and how does the test work in the wider context in society. So as you can see, test accuracy, which is the main thing that we're addressing in this course, is just only part of the journey. So what I hope you've learnt so far is that experimental and analytical studies are important. They're really important as you're developing a test, but the clinical studies are needed to estimate diagnostic accuracy in clinical practice. And I hope you've also reflected on how diagnostic accuracy is not sufficient to know if a test will be useful. And you need to know also lots of things about whether a test is invasive or timely or easy to use, and how it links to patient outcomes. So did you do well in the activities? Well done. And see you in part 6, which is thinking about why the accuracy is wrong if the wrong patients are recruited.